response to our current medications. So today we're going to have a brief. These are some of my observations. First of all, fewer big pharma companies are in the game these days. And yet there are many new investigational agents, including early phase agents. We're seeing an emergence of interest in oral weekly dosing, which is new, and an emphasis on longer acting agents, especially parenteral agents, to address adherence challenges and pill fatigue. There are rare examples of companies working together, and I'll call out Gilead and Merck in this regard because they have worked together. And there are lots of exciting things going on. So I'm really excited about today and being able to talk about some of these things. So in 2024 and beyond, we're going to see a bunch of new things in old classes. So INSTIs, NNRTIs, and protease inhibitors. We're also going to see new drugs being worked on in in our newest class, capsid inhibitors. And then there are two even newer classes that have drugs in the pipeline in RTTIs and maturation inhibitors. We're going to see some co-formulations of these drugs, and we're going to see a whole lot of BNABs all trying to figure out where they fit in this. And even on just this slide, there are 23 unique compounds and a lot of possible regimens for daily or weekly oral therapy, as well as injectable therapy every 3, 4, or 6 months or longer, and potentially also implants. So let's jump in and talk about one of our old friends, cabotegravir. Now we are looking at an ultra-long-acting cabotegravir that could dose every 4 months. And this is a study that was presented at CROI, looking at that 4-monthly dose interval. And here's the study design. And you'll notice parts A and part C in particular. So I want to talk about part A first. This was subcutaneous dosing with the old CAB formulation plus hyaluronidase. And unfortunately, this sub-Q formulation was discontinued because of so many injection site reactions with higher severity and longer duration. So wait a minute, what is hyaluronidase? Well, it's in fancy skin creams, and that's because hyaluronic acid is found in tissues such as skin. It retains water. It has sort of a gelatinous, slippery quality. But hyaluronidase breaks down hyaluronic acid. It makes fluids thinner, and it enhances absorption. And so by using hyaluronidase, the hope is to give higher doses and volumes that would be tolerable. So let's go to part C of this study. And part C looks at different doses of IM injection, and also the sub-Q injection is listed here. Now, on your left, you're going to see a PK graph, and the dotted line and the gray represent the old CAB. And you'll see that the new CAB is represented by the red and the black lines. And then these two lines, blue and purple, are the subcutaneous dosing that is not going forward. So compared to the old CAB, you'll see a lower Cmax for these IM doses at 800 and 1200 milligrams. And here